Merhabalar, sabahki oturumumuza tekrar hoş geldiniz. Bugün bizim ürologlar olarak karşılaştığımız önemli bir hasta grubuyla ilgili 2 tane konuşma dinleyeceğiz. Yaşlı geriatrik hasta grubu oldukça zorlayıcı hastalar olabiliyor. İlk konuşmamız Sayın Jose Medina Polo, Madrid'den bize bu konuda yaşlı hastada idrar kaçıran hastaya nasıl yaklaşacağız konusunda bir konuşmayla başlıyoruz.
Hello, thank you for the invitation to be in the meeting. And I talk about the management on incontinence in elderly patients. First of all, we had to distinguish between different types of patients, because sometimes we think about elderly and the age is not the only important thing. We can distinguish from a healthy elderly patient that the comorbidities and everything is similar to middle-aged people. And we need to think about the fragile elderly patient, because we have to think about the age, about the comorbidity that are so common in this patient, about the polypharmacy that can be related with interaction with other drugs that we are going to prescribe, or adverse effects that are more common. And we need to think about the functional incapacity, both physical or mental, and the psychological and the affective component of the patient. Always we need to think about the family or the social aid that the patient has. So this is the ground that we had, and we had the incontinence that, as you know, is more prevalent with its age. And these symptoms of incontinence had a greater impact because they are related with chronic comorbidities. So the chronic comorbidities is related with incontinence, and the chronic and the incontinence is related to chronic comorbidities. And everything leads to consequence psychological, decreased quality of life, higher risk of fall or fracture, sleep disorder, incontinence fear, and depression and side effects. This can be evaluated in this article by my friend Pedro Blasco. The study was focused on patients with an overactive bladder, and they demonstrate that patients older than 65 years old usually delay the medical appointment due to the symptoms. Many people tend to normalize the urinary incontinence, and they started with adaptive measures. For example, change the urinary frequency, modify the liquid intake, and go for pads and diapers as a normal thing. And pads and diapers are useful, but we need to offer other options that are related with less complication and give a better quality of life. This is the figures of the article. As you can see, there are many comorbidities on this patient, especially in those older than 65 years old. They had 44% of sleep disorder, urinary infection are very common. 43% of patients had urinary infections, and we need to deal with everything. So regarding the treatment, what to do? First, a correct diagnosis of this patient. I like this article. This define the achronic diapers, because in all patients we need to think of all the words that diaper consists of. First, delirium. Second, urinary infection. Third, atrophic vaginitis. Four, pharmaceutical. Five, psychological points. Six, excess of urine output, for example, nocturia. We had the next presentation about nocturia. Also, reduced mobility and stool impactation are very important in this patient. I take this guideline is old, it's 10 years ago, that I like because it contains a section about the management of incontinence in all people. And first of all, they say that we had to evaluate other conditions. In the current guideline, this is also includes, and the saying we need to evaluate cardiac failure, coronary renal failure. We had to improve the diabetes, neurological, depression, and it includes also the metabolic syndrome that is very common on this patient. And starting with the treatment, what do we need? We need to correct this problem. We need to adjust the medication to correct the constipation. to explain about the physical activity and bladder training. For example, this is usually the patient that we had, but if we get this patient, probably the result is going to be better. The patient is slim, is an sport patient, and maybe is 90 years old, but is seen younger. Regarding the guidelines, what is the bullet point? First of all, I mentioned in the previous day, don't treat the asymptomatic bacteriuria. It is true that infections are so common, but not treat asymptomatic bacteriuria. We need to improve the diabetes, and we need to control the diuretics medication. And as you can see, prompted voiding, behavioral modification, and exercise, pelvic floor exercise are beneficial for this patient. And the recommendation is maintaining all the guidelines of this year. But the problem, as you can see, we need to study because an old patient is one older than 75 or 80 years old. There are scarred of studies, and we need to develop studies to demonstrate what is the effect of pelvic floor exercise. Well, about the medication, what medication we had? If we go 10 years ago, the guideline, what focuses especially in oxybutynin. And they say, I like the last recommendation, you need an assessment on the mental function before the medication. And we had to check during that. Why? Because most of the anticholinergics had a potential effect of going to the nervous system. In this article by Counselor, as you can see, many drugs can go into the nervous system. Oxybutynin is moderate, solifenacin is moderate, and trospium is almost known, and festroin is low the disponibility. Here, the problem is that most of the drugs don't have tests in the brain system. And we need to use a calculator about the cholinergic chart that the patient had, because if we analyze the drug that the old patient had, it's very common that more than 50% of the patient had any drugs that had a cholinergic effect, not only the anticholinergics. And this is something that we think. Moving to the main drugs that we had for overactive bladder mainly, I talk about the mirabegron. There are many studies. It was developed in order to reduce the side effect and the brain system effect of the anticholinergics. As you can see, it's a drug that is effective in patients young and older than 75 years. The incidence of dry mouth is below, but it's important that there is a bit higher side effect in patients older than 75 years old. If we go to the PILLAR study that is focused in all patients, first of all, you can see here on the right, the effect is an effective drug in this patient. It's seen that effect is less important in this patient. And regarding the side effect at not very frequently, but many patients had side effects, especially urinary tract infection that is more common in patients older than 75 years old, and also fatigue is more common in this patient. Another sub-study of the PILLAR that is focused mainly in the side effect is compare in this column the differences between older and younger than 75 years old. And you can see the percentage of patients that discontinue the medication is a bit higher in patients older than 75 years old. And regarding the problem, the cardiovascular problem in hypertension is not a real differences. I like this study that is focused on the evaluation on the cognitive capacity with the MOCA questionnaire. And you can see there is no difference in the MOCA questionnaire in patients with impaired and normal results in the test. So it's seen that mirabegron can be an adequate treatment. And finally, with the BELIEF study, they saw the result in order to demonstrate the efficacy in our patient and the benefit in quality of life. As it is seen that is a good drug, but the effect is a bit less than in younger patients. What is the problem of all these articles? Most of them, well, all of them are biased because they are developed by the pharmaceutical companies, but that is published. And finally, I like this study that is focused in all adults with overactive bladder that compare all the drugs regarding the overactive bladder. It is seen that mirabegron has a less percentage of dry matter, but when we evaluate the side effect in combination, all of them, it is seen that all the drugs, anticholinergics and mirabegron, cite a similar percentage of side effect. It is possible that those related with cholinergics are less, but if we sum all, the effect is quite similar. And regarding the effect, there are the drugs are effective, especially the mirabegron and the sulfenazine are the drugs more effective in this patient. So what is said in the guideline now in 2023? We can use this drug in all patients. Mirabegron is effective, but we need to evaluate the cholinergic effect, the drug that the patient had, and we had to do long-term study for our patient. Okay, and what is other alternative? Drugs is an alternative. Botox can be an alternative to our patient. Botox is a safe procedure, and we can do an out clinic basis that is good. But as you say, estrogen, we need to recommend vaginal estrogen to our patient, both with overactive bladder or both with stress urinary incontinence are secure. Most patients had atrophic vaginitis, and as you can see in the guideline, had a high weight of evidence. And move on for the surgery. Can we recommend surgery for this patient? The guidelines say that we can explain the surgery. The results are a bit worse with more complications and less effective than in younger patients, but can be a good alternative. At what we do in our clinic, we don't have a limit of age for urinary incontinence, but in all patients, we need to study very, very good the patient because usually they had comorbidities. They usually had mixed urinary incontinence. For example, in a young patient, it's very frequent to have a pure stress urinary incontinence, but in all patients, they had a mix of incontinence. We had to study correctly, but if the patient had really a pure stress urinary incontinence, I go for the surgery, and I also go for a vaginal tape in this patient. And I think in the future, the bulking agents is going to be the best treatment for the patient. Just to finish my presentation, I include the recommendation by the guideline 10 years ago. First of all, in a patient with urinary incontinence, we need to evaluate two things. First of all, problems with urinary incontinence, what can be related with a complicated urinary incontinence. Those patients with pain, those patients with hematuria can be infection, but can be also a bladder tumor. Patients with recurrent urinary tract infection that we need to treat. Those patients with a pelvic mat or pelvic irradiation, those patients with previous surgery due to prolapse, due to incontinence that require a further evaluation. And more, we need to evaluate the others, the delirium, the function, pharmaceutical, excess urinary input, the reduced mobility, and to evaluate correctly the patient. When we had to study the patient correctly and correct other factors, we had to distinguish between urgency urinary incontinence. We can try with drugs in this patient. and of extraurinary incontinence. When physiotherapy failed, we can go for a surgery. And the other group at patient with a significant post-void result. In this patient, we need to review what's happened, and sometimes we recur to a catheter. So this is my conclusion. It's a difficult task, but the patient we can offer other alternatives, not only the upper and pad. And finally, with the invitation to CNUC and to the ICF the next year, and also felicitation for all the country, because now is your centenary. Thank you very much.
Thank you for your excellent presentation, Mr. Jose. Salondan soru varsa buyurun hocam.
Benim sorum, botulinum toksin enjeksiyonundan hiç bahsetmedin. Yaşlılarla ilgili ilk slaytını ben çok beğendim. Gerçekten iki farklı grup var. Fiziksel aktivitesi normal. Yani senin benim gibi hayatını yaşıyor. Bir de gerçekten fiziksel aktivitesi çok kötü. Felaket idrar kaçırması var. Aile hiçbir şey yapamıyor. Biz bir şey yapamıyoruz. Sonra takıyoruz. Bunlar böyle yaşıyorlar. Öbür grup için botulinum toksin, yani iyi olan, fiziksel aktivitesi iyi olan grup için botulinum toksin enjeksiyonu konusunda ne düşünüyorsun? Çünkü biraz literatür kötü sonuçlar veriyor yaş grubunda da, onun için özellikle sordum.
Okay, I think that for bottles, really, if we follow the guideline, we can put bottles if the patient don't respond to drugs. But in my opinion, the first thing that we have to do in patient before bottles is urodynamics. And I perform urodynamics in all patients. And when the urodynamics demonstrate that the patient had overactive detrusor, I usually offer bottles, because in my clinic, we do in the clinic, we put local anesthesia, and the recuperation is good. We need to inform the patient just about the risk of retention, that is very low, less than 2% in my surgeries. But the problem is that it's true that we had about 25% of patients that do not respond, but it's a good alternative and it's less invasive. To my recommendation, we can offer bottles, but before and urodynamics.
Başka soru veya katkı var mı?
Jose, bu tip hastalarda bizim karşılaştığımız en büyük sorun biraz da kendi meslektaşlarımızdan, bu hastaların bakımından genellikle sadece ürologlar değil, geriatristler, psikiyatristler, nörologlar, birçok hastalığıyla ilgili doktor işin içine giriyor. Ve ne yazık ki o zaman işte polifarmasi ve hatta doktorların sizin ilacınız bu size kötü gelecektir diye kesmesi gibi şeylerle karşılaşıyoruz. Bunları sizce nasıl handle etmek lazım? Nasıl yardımcı olabiliriz?
Well, my recommendation is try to collaborate with them, because if you collaborate with them and they know that you are doing the work well, usually you are going to get the best result. For example, in my clinic, I present in my slide a calculator of the anticholinergic burden. This is not the one that I use. I had one that is in Spanish, was developed in the University of Granada, and it's good. I do this, and if you collaborate, you had interaction with other specialties, the result is going to be better. It's not with elderly, but I'm going to explain what happened in my center with the collaboration with the primary care attention. We developed a collaboration with primary care attention. The only thing was to make protocol, to make everything easier, and the number of patients with incontinence that what referred to our department increased to 100%. And it was well referred.
Thank you very much for the nice speech. Tekrar teşekkür ediyoruz.
Thank you.